Good morning, folks. We've got people rapidly joining. This is the Protect Our Care policy briefing on Medicaid, SNAP, and ACA changes. So we're going to give it a minute to calm down. We've got a really big group today, and then we'll go ahead and get started. Good morning for those just joining. Welcome to the Protect Our Care briefing on Medicaid, SNAP, and ACA changes in HR 1. We've got a lot of folks joining, so we're going to go ahead and give it a minute before we get started. Good morning, everyone. Sorry to the early birds who are hearing me do this over and over. You're joining the Protect Our Care briefing on Medicaid, SNAP, and ACA changes, and we've got a lot of folks joining, so we're going to give it a minute and get started. Good morning, folks. You're joining the Protect Our Care briefing on Medicaid, SNAP, and ACA changes. We will get started in like 35 seconds. We've got a lot of folks joining. All right. We're still going to have people come in, but I'm going to go ahead and get us started. Good morning, everybody. My name's Kathy Wallagora. I use she, her pronouns, and I am with EverThrive Illinois and Protect Our Care Illinois. We're so grateful to have you here, though we wish we didn't need to be having this conversation. Today, we'll be going over not all, but some, the most important and impactful changes to Medicaid, SNAP, and the Affordable Care Act as a result of House Resolution 1, the reconciliation package, the one big beautiful bill, if you're going to force me to say it. But we'll go over what this means for Illinois and kind of where we go from here. To get us started, this is an overview of everything we're going to cover, but I want to pause and answer the question we're seeing a lot before we get going. We will be sharing this recording. We will be sharing these slides. They're going to go up on the Protect Our Care Illinois website. I believe we may also be able to email them to attendees. But yes, you will receive this resource. Also, we're going to have folks put questions, as you're already doing, into the question and answer box. We'll answer some of them during the presentation, and we'll also have time for Q&A at the end. So please put questions into the box as you have them. This is what we're going to go over. It's a lot. I'm not going to spend a ton of time on this slide, but want you to know we will be going over the most important changes as we see it to Medicaid, the Affordable Care Act, and SNAP as a result of this legislation, including timeline for changes, as well as general next steps for what the state of Illinois can do to mitigate harm. And I think that's going to be the theme you hear today. We worked really hard to try and prevent this bill from passing, and we succeeded in making it less bad than it could have been. It's a hard victory to hold on to, but an important one. So, what we'll talk about today is how we continue to make this less bad. What are we going to do to delay? What are we going to do to mitigate? How are we going to help folks navigate this changing system while building towards something better down the road? So hopefully you'll walk away with a lot of understanding of what was in the bill, what wasn't in the bill. It was such a chaotic time, it can be difficult to track and where we go from here. Protect Our Care, you probably know us if you're in this webinar, but Protect Our Care Illinois is a statewide coalition of healthcare advocates, providers, consumers, and other stakeholders. We have about 100 members across the state who are working together to protect the Affordable Care Act and Medicaid from federal cuts. We will continue to work together to save off any additional federal cuts, to call attention to them, to push back against federal cuts, while also thinking about how to build a better healthcare system in the long term. We've got a whole host of incredible presenters today, people who are experts in so many of these topics, who are leaders of Protect Our Care. I'm not going to read off everybody's names. I'll allow them to introduce themselves as they speak, and know that everybody's contact information is towards the end of the slide deck. So if you have follow-up questions, you can feel free to reach out to folks directly. And with that, I'm going to turn it over to you, Naya.
I think
Uh,
this may
I
actually
think this
be
is
Nadine.
Nadine. Yeah.
Oh,
Hi,
I'm
Nadine.
sorry. I
That's
already
okay.
messed it up.
You're fine.
No worries. Good morning, everybody. Thank you so much, Kathy. I switched things up on Kathy. That's why. I'm Nadine Israel. I use she, her pronouns, and I am with AIDS Foundation Chicago and very proud to be with Protect Our Care Illinois as a coalition member and actually one of the folks that got in that room during Trump 1.0 to talk about how we were going to work together to fight back. I really appreciate everyone making the time to be here. So these next few slides are going to be just a basic overview and level setting when it comes to Medicaid. We want to make sure that when we're talking about what changed, that we understand what was and what is right now. And that's the purpose of these slides. Next slide, please. Okay, so when thinking about Medicaid, this is an overview of healthcare coverage in Illinois, so including Medicaid and the ACA, I should say. When thinking about Medicaid, the first thing that we want to make sure we're all on the same page on is what Medicaid is called. So in Illinois, Medicaid is known by lots of different names. So you'll see those names here: all kids, moms and babies, AABDs, aged, blind and disabled, so seniors and folks with disabilities. ACA adults sometimes are called Medicaid expansion folks. All of these folks are Medicaid. They have their health insurance through Medicaid. What is Medicaid? It's free comprehensive health insurance. It's based on your income level. It's for folks who are in or near poverty, folks who are low income. In Illinois, Medicaid is the health insurance. It's how people have their health insurance for about 3.2 million people. That translates to just under a quarter of our population has their health insurance through Medicaid. So that's how big the Medicaid program is right now, and how much it impacts people's lives. Generally speaking, in terms of how it's structured, in terms of how it's paid for, especially because we'll talk a lot about how some of the payment changes that will happen. The state, Illinois, pays some of the costs, and the federal government pays some of the costs when it comes to the Medicaid program. The percentage changes based on what population, sometimes what type of service. Generally speaking, it's going to be 50-50, meaning for every dollar that is spent on Medicaid, the state of Illinois is paying 50 cents and the federal government is paying 50 cents. But you'll see throughout the rest of the presentation that for some populations, for some services, that structure looks different. So that's Medicaid. Now, so we're talking again about a quarter of a million people, a quarter of the population in Illinois, roughly. ACA Marketplace, right? Obamacare, Affordable Care Act, Health Insurance Exchange. These are private health insurance plans, right? That are sold on the marketplace. In Illinois, there's about 450,000 Illinoisans who benefit, who have their health insurance through the marketplace. They're affordable for most people. They become affordable because of the subsidies. The subsidies come from the federal government right now, and they help people afford their premium. The premium is that monthly payment that you pay when you have private health insurance in order to have the private health insurance. So the subsidies help with the premium. And again, most people who have a marketplace plan, they have a subsidy to help them afford it. That's how they're able to afford it. Otherwise, it would be unaffordable, and we would be back to before the Affordable Care Act was passed. Important to know, Illinois is transitioning to a state-based marketplace, starting with plan year 26, that's calendar year 26. Enrollment does start for that in the fall of 2025, so fall of this year. That will give us hopefully a little bit more control over our own marketplace, but we'll find out more as a rollout happens. So basically, if you look at Medicaid and the ACA in Illinois, in terms of who we're talking about 3.65 million people total, which is about 30% of the population. Our state's population is 12.8 million people. So again, most of that, 3.2 million is Medicaid, and the rest is marketplace. Important to note, we also have what are called state-funded immigrant health coverage programs. We'll talk a little bit more about those later in terms of impact of the changes on immigrants specifically. There was a whole other webinar that happened last week on that if you want to find out more. But the important point here is we want to make sure we're all on the same page on is that there are state-funded, so state-only money that goes towards health insurance coverage programs for immigrants. Next slide, please. Okay, I talked a little bit about Medicaid financing before. So again, it's a partnership between the federal and state government. That specified percentage, when I said, okay, for every dollar spent, there's a certain percentage that the federal government pays, there's a certain percentage that the state pays. That is called FMAP. So you'll hear it referred to as FMAP, Federal Medicaid Medical Assistance Percentage. You'll hear and read FMAP a lot. So that's what they're talking about. They're talking about that percentage. This bullet, the next bullet goes into like how the FMAP is calculated. That FMAP isn't the same for every state. It's a little bit different. The reason why is based on the per capita income of the state. I think this piece is less important for all of us to remember, but the important part for us in Illinois is that to understand that what the FMAP means and that it's different based on some populations and some services. So the sub-bullet here is what I was mentioning earlier. Generally speaking, the FMAP for Illinois is 50%, meaning for every dollar spent, the state of Illinois is paying 50 cents, the federal government is paying 50 cents for Medicaid. There's a call out here for ACA adult folks, Medicaid expansion folks, because the FMAP for them was 90%, meaning the federal government pays 90 cents and the state pays 10 cents of every dollar spent just on the ACA adult folks, the Medicaid expansion folks. And then the last bullet gives you a sense of, for the Illinois share of the money for Medicaid, where it comes from. So general revenue, healthcare-related taxes, et cetera. Okay, HR 1. I'm not going to call it, I'm just going to say OBBB, whatever, OBBBA. That was a budget reconciliation bill that was signed into law by President Trump on July 4th, as we all know. It's really important to remember that this law is responsible for the most significant reductions in immigrant eligibility since welfare reform, which happened in the mid-90s, in 1996. So when thinking about impact, that's a population that we're going to have to do as a collective, a lot of work to make sure to do our best to mitigate the harm that Kathy was talking about. Larger point, the bill cuts $1 trillion. I was trying to do how many zeros that is, and it's too many zeros for me. But it's $1 trillion over a 10-year period, basically, out of Medicaid. And the Congressional Budget Office, which is a nonpartisan group, said that the estimate is that just under 12 million people across the country are going to become uninsured by 2034 because of this bill, because of this law. So we're going to go through the main parts of the law. That's what's coming next. The timeline for each, because each part of the law, in terms of implementation timeline, is different. The impact on Illinois, and then the next steps that we need to take to mitigate harm, and accountability. So I just want to say one more thing on this piece, is that there's a lot of really horrible things in this law. And the last thing we want is to leave folks feeling paralysis or feeling like they can't do anything. The point of this webinar and this briefing is to make sure we understand what was in the law, how we can mitigate harm, how we can hold folks accountable, and how we can continue to dream and work and plan to have a healthcare system that works for all of us. Next slide, please. Sorry. Okay. So it's also important to talk about what was proposed, but that did not pass in the bill, right? Because there were some pieces, like Kathy said, that we were able as a collective to not have included. So the FMAP, that percentage reduction that was proposed from 90% to 80% for expansion states only, Medicaid expansion states only, that did not pass, because it was basically going to punish states that use their own money to cover immigrants under Medicaid by lowering their FMAP. That part did not pass. What else didn't pass? The FMAP reduction for states to regular FMAP from 90% also did not pass. these two are really, really important. It would have been even more devastating in terms of dollars coming in to cover Medicaid and provide health insurance for millions in Illinois. So the only FMAP reduction that passed lowers the FMAP for emergency Medicaid for non-citizens to the corresponding FMAP rate for ACA expansion category. So that would be, depending on what it is, but generally it's 90%. So that part did pass. So what does that mean? This means that Illinois will get regular FMAP rate, which is 50%, for Illinois non-citizens who are ages 19 to 64, that ACA age range, who would be on the ACA, who would qualify for the ACA, except because of their immigration status, they don't. Okay, other things that were discussed that did not pass: no per capita caps or block grants, reduction of FMAP for family planning did not pass, no prohibition on states claiming federal matching during a reasonable opportunity period. And this is an important one for a lot of populations, certainly the LGBTQ population. No, the ban on gender affirming care in the Medicaid, in marketplaces, essential health benefits. That part did not pass. And then no bans on telehealth. Next slide, please. Okay, what passed that will impact Illinois most significantly? So the projection here is that 330,000 Illinoisans are going to lose coverage, and the state will face about a 51 billion, with a B, dollar reduction in Medicaid expenditures in the next decade. So that's basically between now and that 2034 timeline. So that's the estimated direct impact right now on Illinois. Estimates also show that most significant combined loss of federal funding and eligibility is going to come from the work requirement for most of the ACA adult population. So that one is going to be vital for all of us to be on top of and do everything that we can, including the state, to minimize the harm from the work requirement, because most of the losses of eligibility and the money that we will lose are going to come from that work requirement. People losing their coverage because they can't get through the paperwork or the process of the work requirement on a regular basis. Next slide, please. In terms of states' finances, so we talk a lot about with Protect Our Care in terms of the impact on the human. That is the most important part in my viewpoint: impact on providers and impact on state. The state needs money in order to provide Medicaid, right? At least their share. There's two pieces in here that were in this law: provider taxes and those state-directed payments. Basically, both of these are ways that the states are able to generate more money in order to be able to finance their portion of the Medicaid program. So the law made changes to both of those to make that harder, so that the states, including Illinois, will generate less money. So for the provider taxes, most significant loss of federal funding to Illinois is going to come through the cap on provider taxes. It's going to go down to 3.5%. I believe the cap was at 6%, or is at 6% right now. Over time, it's going to go down to 3.5%. Just this piece could lead to a loss for Illinois or could lead to a loss for our healthcare system between 4.8 to 11.2 billion in terms of losing federal funding that would be coming in Illinois. And this is just for the first 5 years of implementation. State-directed payments, this piece allows states to direct payments to Medicaid managed care for specific payments for providers. Again, it's essentially a way for the state to raise more money in order to be able to pay for their share of Medicaid. That ability is restricted, which means the state will have less money over time in order to pay their share of Medicaid, making it harder to cover the same services and the same people. Next slide, please. Okay, I believe I am going to Stephanie or Carrie next.
Me.
Awesome, thank you.
Hi, everyone. I am Stephanie Altman from the Shriver Center on Poverty Law, and I'm going to talk about some of the Medicaid program eligibility changes and then turn it over to my colleague, Carrie Chapman, to talk about the remaining ones. One thing that I want to point out about both of these sections and a lot of the details that we're talking about today. This is not every provision that's in the statute. It's definitely not every detail that will eventually come out in terms of these provisions. Guidance hasn't been issued yet, so we will see rules at the federal level come out, of which there'll be comment periods and potential changes to. We will see guidance come out from the Centers for Medicare and Medicaid Services, which will further detail these provisions. And there could even be litigation or delays to some of these provisions. So what we're talking about now is just sort of a summary of what is in the law, but there's kind of a long way to go before we even get to implementation at the state level. And as Nadine pointed out, points where we can get involved as advocates. So the provision, as Nadine mentioned, that is going to cause the largest eligibility reduction in every state, including Illinois, which is estimated at 330,000 for the state of Illinois, is the work requirements provision. It also is going to cause a tremendous administrative burden on our state agency and cost a lot of money to implement. It requires states to make Medicaid eligibility conditional on people who are in our ACA adult population, so 19 years old to 64. They need to be able to show after the provision goes into place, in order to keep Medicaid, that they are reporting on their work or their participation in other qualifying activities for at least 80 hours a month. This is really burdensome, not only because it requires work or being in school or participating in these activities. In the 2 states that this has been tried, it really shows that the major burden isn't working or participating in the activities, it's being able to prove that you're doing so. So the administrative burden of people proving every month that they're engaging in these activities is the real cause of the loss of Medicaid eligibility that we need to prevent. You have to show compliance when you apply. You have to show that you're complying with work requirements when you renew. The renewals are every 6 months. There'll be a compliance review and looking at the 1 to 3 months right before you apply. This is incredibly burdensome, and you're going to have to report on combinations of community service, educational programs, participation in work requirements, students, paid work, in order to prove to your state that you're engaging in this at least 80 hours a month. Like I said, there's a long ramp time in which there will be rules and guidance coming out on exactly how people will be able to prove this or engage in these activities, and the state will have the burden of, but we'll have to actually implement and write some of this at the state level. Right now, the effective date is the states must do this no later than December 31st, 2026, or they can do it earlier if they want to. We don't expect Illinois for any reason to opt to do this earlier. It is also possible for the federal government to exempt states from compliance, so delay them putting this into effect until 2 years later, December 31st, 2028, if the state is demonstrating good faith trying to comply, submits progress reports, but isn't able to implement their system yet. So it could be delayed. Next slide. So there are exemptions to the work requirements. Again, this is just what's in the statute. We don't have every exemption that will ever be, in the rules and the guidance and in the state implementation. But in general, the exemptions or carve-outs for these populations, which will itself be an administrative burden on people on Medicaid to prove they're in an exempted category if they can't meet the work requirements, and for state Medicaid agency staff and Department of Human Services staff to administer and try to figure out who's exempt, who is meeting work requirements, and who can stay on Medicaid. This is a list of some of the requirements and exemptions, or exemptions from the requirements. One of the ones that has been pointed out, and I'd like to point out, is parents, guardians, family caregivers of children who are under the age of 13. under the age of 14, so 13 and under, as well as women who, people who are pregnant, people with disabilities, and some of these other exemptions here. There are other optional exemptions that the state will be able to implement, and there'll be a lot more rules and guidance on that, but not everybody between 19 and 64 will have to meet the work requirements. There is going to be a significant impact on coverage, as we said. Estimates range from 270,000 to 500,000 people in Illinois could lose eligibility. That's a huge range, obviously. We use the estimate that the state of Illinois had originally estimated at 330,000. We hope it's a lot less, and we believe the state and all of us can do a lot to reduce that, but that's what we're looking at right now. That's our job. In the 2 states this has been done, penalties related to work requirements were essentially Medicaid cuts. You're cutting people off of Medicaid. They haven't been shown to improve employment, so that's supposedly the goal of them. They have not been shown to do that. Most working age Medicaid enrollees who can work already work. They've been shown to just add administrative burdens, as we mentioned, proved ineffective in the states that implemented them. Cost, I think in one of the states, $100 million to implement. And just have a disproportionate harmful effect on people, especially with mental health and substance use conditions, those with arrest and conviction records, and others that have very significant barriers to employment. And to even add insult to injury, if a person is denied or disenrolled due to not meeting these work requirements, they also become ineligible to receive financial assistance on the marketplace. So they can't even get into the marketplace with financial assistance if they lose Medicaid because they weren't able to prove that they were working or prove they're in an exemption. And these are the estimates of people to lose coverage. And we're going to try, all of us, including the state, to keep that as low as possible. So there are other key changes in Medicaid. We're not going to go through all of them. Here are some of the ones that we think are going to be most difficult. There are more frequent and onerous eligibility reviews, so checking if people are eligible for Medicaid, which just creates a burden on everyone who's on Medicaid, and it also increases the burden on state agencies, including that they have to look at ACA adults, Medicaid expansion adults, every 6 months to redetermine if they're still eligible. It cuts the retroactive, or what's called backdating, eligibility period when people apply for Medicaid now. If they're eligible 3 months before the date of application, they can get Medicaid back. It's a really important part of the Medicaid program. It cuts that to only 1 month for ACA adults, 2 months for other Medicaid applicants. And this really hurts hospitals in particular, and it hurts Medicaid recipients, obviously. But often, sometimes people don't know that they're off of Medicaid, or they become newly eligible and they don't know, and they seek medical care and then apply. So it really hurts people who have already received medical treatment and then apply for Medicaid. It requires Medicaid programs to regularly obtain address information, provide all this information to the Department of Health and Human Services at the federal level, get information like Social Security numbers to identify duplicate enrollments. While that sounds like, why wouldn't you want to do this? It will be another administrative burden on Medicaid enrolled individuals to have to turn in voluminous information all the time for renewals, and for the state of Illinois to try to get the information to the federal government. It also imposes cost sharing of $35 per service, and these are some people who have zero income. So it's not everybody even has income in the ACA adult population. But if they have income between 100% and 138% of the federal poverty level, which is still quite low, they have to pay $35 per service, despite all the evidence that's been shown over years of the harms of having a copayment for services. It has usually a chilling effect on people even going in for services because they're afraid they can't pay the copayment. And it usually amounts to just a provider cut of $35 per service. There are some explicit exemptions for primary care, mental health and substance use disorder services, and it limits some of the cost sharing for prescription drugs. but cost sharing in general is just another penalty in the Medicaid program for the expansion population. A couple of other things that aren't on this slide that we want to mention. It also restricts eligibility for long-term care services and supports by capping the home equity limit. So how much can you have in equity in a house and still be eligible for these services? It's going to make less people qualify for those.